Let's join Dr. Robert Docks for a discussion on trauma, resuscitation, and wound care.
I'm actually going to start with resuscitation before trauma. So this really should be called resuscitation, trauma, wound care. So let's do a couple of resuscitation things. Now, it wasn't on my boards, but David tells me when he took his boards, there was one or two questions on BLS, ACLS stuff. So we'll just do a blitzkrieg on the things that may have changed that you should be aware of in BLS and ACLS. So the BLS, the basics, if someone goes down, if I have my cardiac arrest right here, right now, please call for help. And then just start pounding on my chest. Compressions first. It's no longer A, B, C, it's now C, A, B. Just start pounding on my chest. Then think about airway and breathing. When it comes to the pulse check, looking for the carotids, we've been teaching the public, don't do that. You don't know what you're looking for. And if we do it very briefly. Don't waste your time going, well, is it here? Is it here? Is it here? Is it there? No, just brief. If you don't find anything, just start pounding on the chest. And then when the monitor shows up, then it simply becomes a matter of, is it a shockable rhythm or non-shockable rhythm? So if it's a non-shockable rhythm, it's really easy. It's either asystole or it's PEA, non-shockable rhythm. And asystole is really, it's really easy. It's a fatal rhythm. Atropine is out, no more atropine. You can give epi, and then consider calling it fast because it's a non-viable rhythm. All right, PEA, here you're supposed to do that differential in your head real quick, the 5 T's, the 6 H's. I'm not going to read them, but it's all basic ACLS. That hasn't changed. You do the differential diagnosis in your head. When it comes to, shockable rhythms, well, just start shocking. That's your first action. Defibrillated 200 joules times 1, just go right back to CPR. Don't waste time checking for pulses again. Just go back to CPR. Do that for a couple of cycles, 5 cycles, and then defibrillate again. And then you can start your vasopressors, epinephrine, continue with CPR, and if it's a shockable rhythm, defibrillate again, and then down the bottom of the line is give the antiarrhythmic amiodarone. All right, the other thing on resuscitation, starting to see questions pop up on the in-service, and if you do any inpatient work, how many hospitalists are doing inpatient hospital work here? Okay, all right, the whole sepsis thing. For those hospitals, aren't you tired of this whole sepsis thing? Oh my God. Oh God. If I get one more memo about it. All right. So you're going to want to know for the boards is at least the definitions. And the one I think they're going to go with is the CMS definition. And they break this out to what is sepsis? It's the SIRS, systemic inflammatory response syndrome, plus a source of infection. So SIRS is over there, 2 more of those. Severe sepsis is when you have sepsis plus lactates up and or organ dysfunction, and then you have septic shock, which is defined as severe sepsis with a lactate greater than 4, or hypotension despite fluid resuscitation. That's the CMS definitions. For those of you in the know who do a lot of critical care, the Society of Critical Medicine came up with their own definition a year and a half ago. I've put it up here. They want you to calculate out this SOFA score, which is not very easy to calculate out, the full SOFA score. That will define if they have a life-threatening organ dysfunction, and then if they have infection, that's completely clinical suspicion. And they have, they take out the severe sepsis, and they have a different definition of septic shock. They also use, because the SOFA score is so complicated, they use this Q SOFA score, this quick SOFA score that you can use also. But I put that in there only for completeness sake. If I was going to study a slide for the definition, I think I would do the CMS definition. I think that's what I would probably use because that's what is still being used in your hospitals. The thing that I would know, not go crazy about definitions. I wouldn't study the definitions that much. Pretty straightforward. The thing you want to know is these 4 management steps. That is, you should measure the lactate, obtain blood cultures before the antibiotics, administer broad-spectrum antibiotics within 1 hour of the recognition of sepsis, and administer a bolus in the cases of hypotension of 30 mils per kilogram bolus. And think about it. I'm a 70-kilogram man. That is 2.1 liters of fluid. By the way, you get dinged if you just give 2 liters. It's 2.1 liters. It has to be the 30 mils per kilogram, believe it or not. Okay, trauma. On to trauma. Trauma facts. Trauma is the leading cause of death, ages 1 to 44 years of death. There are approximately 199, rounded off, 200,000 deaths per year in the United States from trauma. As I mentioned, and David mentioned, I started giving this course in 2005 when we first started. And I obviously edit this lecture year after year after year. And when I first started this lecture, I would then say the number one cause of trauma deaths in the United States is MVAs. And when I first started this course, the number was up around 45,000, 50,000. And over the years, the last 12, 13 years I've been giving the course, that number has slowly gone down. Probably multifactorial. More people wearing seatbelts, hopefully, better cars, less DWIs, hopefully. Multifactorial. The number is now down to 32,000, 33,000. It's no longer the number one cause of trauma deaths in the United States. What's now the number one? Firearms. That's the data. Firearms. All right, so you have the trauma victim. You do the ABCDEs. That's the primary survey. This is basic ATLS. ATLS. Airway, breathing, circulation, disability, exposure. For those of you taking the ATLS course. I'll just give you the highlights that you need to know or you might want to know. Airway. When it comes to opening the airway, in ACLS, it is head tilt, chin lift. Okay? That's ACLS. In ATLS, or in trauma, you just do a jaw thrust. You don't do a head tilt, chin lift, and move the cervical spine. Okay? So it's a jaw thrust. Breathing, you think about, can I ventilate this patient? If I can't ventilate this patient, what's wrong with their chest? Do they have a flail chest? Do they have a tension pneumothorax? If I can ventilate, but I can't oxygenate, you think about pulmonary issues, pulmonary contusion, foreign bodies, things like that. Okay. Circulation. When it comes to circulation, control the hemorrhage. Tourniquets are back. This is from our military experience abroad, lessons learned. Tourniquets are back. They're lifesavers. We're using them now in the ER in our trauma cases. All right, monitor their vitals, of course. 2 large Aurora IVs, lots of fluids. O negative is the resuscitation blood of choice until you get them type and cross-match. When it comes to the pediatric patients, fluid resuscitation, know the number. It's 20 mils per kilogram. That's the fluid resuscitation. And I don't care if you use normal saline or lactated ringers. It doesn't matter. After 3 boluses and they're still hypotensive, then you go to blood. That's called the 3-in-1 rule. All right. Disability, there's this mnemonic disability. You're just doing a quick neuro. Boom, 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 boom. Are they alert? They verbal? They got pain? Or are they completely unresponsive? Disability. Exposure, you're going to get off all their clothes and turn the heat up in the room to prevent hypothermia. So then the secondary survey is essentially starting from the top down again. So let's just start from the top down and do a head injury case. 22-year-old male presents to the emergency department after being struck in the right side of the head with a baseball bat. Bang. This happens. This is a Friday and Saturday night thing that happens in my emergency department. Myself and my colleagues, when they come in and they got struck in the right side of the head with a baseball bat, I just can't help myself. I got to ask him, what were you doing to get struck with a baseball bat in the head? Almost invariably, the answer is, I was minding my own business. I am convinced the greatest risk factor for getting struck in the head with a baseball bat is minding my own business. That is almost always the answer. Minding my own business. So some guy just rapped me in the head with a baseball bat. Okay. So this gentleman or gal walks in with this baseball bat struck in the head, walks into the ED, says, I was just minding my own business, got hit in the head. My vital signs were fine. The GCS, the Glasgow Coma Score, was 15, which is normal. Right side of the scalp has a large soft tissue swelling, no neurologic deficits. 15 minutes later, the patient is minimally responsive, and the right pupil is now fixed and dilated. Whoops. A stat CT scan is likely to show A, a right-sided epidural hematoma, B, right-sided subdural hematoma, C, a basilar skull fracture, D, an intracerebral contusion. Which is it? Great. This is a right-sided epidural hematoma. Okay. So, why is it an epidural hematoma? So what happens with the epidural hematoma, as was in that case presentation, you walk, talk, deteriorate. That's the classic. Why? Because you struck the middle meningeal artery on the right or left side of your head, okay, which is in the parietal region of your scalp. Bang, you hit it, this artery ruptures, and it bleeds. So initially, you're okay, and then very rapidly you deteriorate. Probably the most famous case of this that I'm aware of was the actress Natasha Richardson, when she was skiing up in Canada, fell, banged her head, got up, apparently got down to the bottom of the mountain, and then very rapidly over the next couple hours just deteriorated and died. Some of you might remember that case. So that's the epidural hematoma. The subdurals happen more commonly in patients who have brain atrophy. That's our elderly or the alcoholics. And the reason that happens is that with the cerebral atrophy, you have those bridging veins from the dura, okay, that they now bridge and they're longer and they're just tethered and they break easier. So that's the subdural. That comes down a lot more slowly. And intracerebral hemorrhages happens, you'll pick those up, not on the initial CT typically, but a later CT, because it's like bruising on the brain. You'll see the blood there. All right, epidural hematomas, subdural hematomas, this is what they look like on CT. I've never seen them show up on a board exam, but just for your own knowledge, the epidurals have this sort of egg-shaped, it's sort of convex. The subdurals are more crescent shape or concave. That's what they look like. Okay. All right. Which of the following statements is false? I'm sorry, let me get that clear. Which of the following statements is false? Protective helmets reduce head injury and death in motorcyclists. B, protective helmets reduce head and facial injuries in bicyclists. C, protective helmets reduce head and facial injuries in skiers. Or D, IV steroids are useful in the management of head injuries. Which one of these is false? Excellent. Okay, so the D is the answer. IV steroids are not useful in the management of head injury, but helmets are very useful in preventing injury in motorcycle accidents, bicycle and skiing helmets. They're all very useful. It's very interesting how state legislatures keep withdrawing the rules on helmet laws on motorcyclists. More and more states keep doing that, so there's more and more states where you can ride, obviously without a helmet. I don't get it. I understand there must be something about the wind blowing through your hair while you're on the motorcycle, but obviously I can't appreciate that. You know, but more and more states keep repealing those laws. All right. Steroids, however, provide no benefit in head injury, possibly harm. For a long time, we were using steroids in cervical spine injuries. We no longer do that. So steroids are out in trauma. Just remember it that way. Steroids are out in trauma. Okay. How about minor head trauma in children? So let's talk about minor head trauma. Here's the AAFP guideline. Note, it's the 2 to 20-year-olds, okay? So they said, listen, if you got a bump on the head and you have a normal mental status, a normal neurologic exam, and no evidence of skull fracture, and no LOC, just stop. Reassurance. Stop. They don't need a head CT. Johnny, little Janie, or the high school football players that get a kunk on the head, they don't need a head CT, okay? Even if they had brief loss of consciousness, you can just observe, okay? You can observe. Why? Because if you hit those things I just mentioned, the chance of you finding something on CT that you're going to do something about neurosurgically is less than 1 in 5,000. Less than 1 in 5,000. And you'll notice they didn't put in there about vomiting or anything like that, because vomiting is not predictive at all of a head injury. I know that was one of the first things we learned in medical school, that if you're vomiting, that can mean increased intracranial pressure, and oh my God, there can be something going on in your brain. It's been shown over and over that vomiting is not predictive of an intracranial injury, okay? So don't use the vomiting thing, all right? And because, I mean, kids, they bump their head, they just vomit. I mean, this is what they do. I mean, how many, I assume many of you are parents, right? All right. What does your 3 and 4 and 5-year-old bump their head, fall down, hurt themselves, cry like crazy? What's the next thing they do? They vomit, right? Yeah, they're little perfect puking machines, okay? All right, so it's not predictive, okay? Not predictive. All right. Now you notice that first guideline was for children 2 and older. Under 2, AAP, the pediatricians say we should treat these a little differently. And really the answer should be under the age of 1. A little more concerned about under the age of 1 because their skulls are little eggshells, not as hard as your and mine, okay? So they're at higher risk. So who do you worry about under age 1? This is the ones who have very, very large scalp swelling. The younger they are, the greater the risk. If it's an abuse case, or you got this swelling in your head and we don't know how that happened, oh, that doesn't sound too good. All right, those you get worried about. Again, they even said in this age group, vomiting is not a predictor. So you make up in your mind, is this a low-risk situation? You have reliable parents, you just watch them. If they're high risk, any of those high-risk things, I have those 5 up there, you can go right to CT. I understand that. If you have an intermediate risk, then observing them for a period of time is just fine. Just fine. Okay, that's what you do. All right? Why not just CT them all? Heck, I'm not going to take on the medical legal risk. This kid maybe has something in his brain going on. I'm not going to, take that risk. Just CT it. Don't worry about it. As you know, and this has come out more and more and more in the last couple of years, the amount of radiation associated with CTs. This was actually an in-service question a year or two ago, I think it was, where I use this commonly with my parents or patients. I equilibrate the amount of radiation to the number of chest x-rays that the patient might receive. So in other words, a head CT, I tell the parents or the patient, that's the equivalent of about 80 to 100 chest x-rays. Parents get that. That's a lot of radiation. That chest CT or abdominal CT is the equivalent of 200 to 400 chest x-rays, depending on the size of your patient, what machine you have, etc. And it has been shown that these are linked, especially in children, to future cancers. Small risk, small risk. I'm not saying every kid who got a head CT is going to get a cancer, but there's a small but true risk of later cancers. So this is another perfect situation in which you have informed consent and shared medical decision-making with the parents. All right, on to the chest, back down to the chest. Chest wall, you worry about rib fractures. They're common, they're painful, give enough pain medicine. They hurt for a while. Anybody here ever have a rib fracture? Okay. Hurt for more than just a day or 2, I bet. Oh no, how? A month. Typically, they'll tell you 4 to 6 weeks. It hurts like bejesus. Yep, absolutely. All right, lungs. What do you have to worry about the lungs? You can have hemopneumothoraxes and pulmonary contusions will show up later on. And the heart and great vessels, you're going to get an aortic tear from a rapidly deceleration injury. That is the MVA where you're just going 50, 60 miles an hour and suddenly, boom, decelerate. Your heart is free-floating in your mediastinum. That swings forward. Your aorta is tethered to your back. That's where it tears. One I'll just mention to you, and I think Dr. Geary mentions it also in his lecture on sports medicine. Just be aware of this condition called commotio cordis. This is where you may hear about these cases in which children are on, the classic is the little league field, but it can be any field, or hockey pucks hitting the child in the chest, or the thrown baseball, batted ball hits the child in the chest right before the peaking of the T wave, and it's just this really vulnerable time, and it'll throw the patient into a polymorphic VTAC. And this is why there's now a lot of movement, if it hasn't already happened in your community, to put defibrillators at the Little League fields. All right, very rare these happen, but when they happen, they're very dramatic. And so that's commotio cordis. All right, down to the abdomen, spleen, splenic trauma. Who's at risk? Those patients who have splenomegaly, the young adults who have mononucleosis, for example, or hematologic diseases. Be aware if they have a splenectomy, yes, you need to then give them the vaccines post-splenectomy vaccines, not just for pneumococcus, but for the other encapsulated organisms also, Hib and meningococcal vaccine. So all three of those, best given about 14 days after the splenectomy, because that's when you get your best immunologic response. This is just a review slide. If you want to have more information about how, when, where to give the pneumococcal vaccine, Hib vaccine, and meningococcal vaccines to the patients who have splenectomies. This came right from the New England Journal. All right, moving on. 31-year-old male is brought to the emergency department after a steel scaffold struck and pinned his left lower extremity for 2 hours before extrication. On arrival in the emergency department, his vital signs are stable and the ABCs are normal. Good stuff. Left leg, however, from the hip to the ankle is swollen, ecchymotic, and tender. Sensations intact. He's got pulses, dorsalis pedis and posterior tibial. The lab shows H&H 13 and 37, good, but his urine dipstick is positive for blood. The urinalysis, however, doesn't show much blood on microscopic examination, 0 to 2 red cells. This patient should be admitted for the management of A, rhabdomyolysis, B, compartment syndrome, C, renal contusion, D, hemorrhagic shock. Good, this is rhabdo. Yeah, this is a classic case they throw up on occasion in the boards. So why is this rhabdo? Well, this is a bad crush injury. All right, so this is a bad crush injury in which there's a lot of myoglobin released, and that's what's now spilling into the urine. When you do your dipstick, it'll say, it just sees myoglobin, not hemoglobin, but it just reads positive. But then when you do the microscopic, there's no blood there. So that's myoglobinuria that's coming up on the dipstick, all right? So rhabdomyolysis, be aware of. How you treat it? You treat it with lots of fluids. Fluid, and more fluid, okay? You're trying to avoid the myoglobin gumming up your kidneys. Okay? That's the bottom line there. It happens in trauma cases. You'll also see it, for example, it's been reported not uncommonly in military recruits who just go out and they start marching 25 miles and are not prepared for it. Happens to people who just start exercise regimens who are not used to doing this. One of my residents and I actually wrote a case report that we published of a young man who we admitted for a couple of days with rhabdo who had the second highest CPK ever recorded. His CPK was 1.2 million. Oh, yeah. The highest ever recorded that we found in the literature was 1.5 million. We asked him, what was he doing? He said 2 days ago he started the exercise program P90X. Boy, did he start the exercise program. Yeah, so he was hurting. He was all upper extremity pain. He was really hurting. But when you're young and healthy and you have good kidneys, you handle this very well. He did fine. He was in the hospital for 6-7 days, but he did fine, had no renal failure. That's the good news there. Okay. Compartment syndrome. For those of you who pick compartment syndrome in that case, good thought, and that person's at risk for compartment syndrome, but does not yet have it. How do you document, or when do you know a patient has compartment syndrome? The magic number is when it's in the compartment pressure is greater than 30 millimeters of mercury. That's the definition, and that's when you're going to run into problems with compartment syndrome, and you get some ischemia of the muscle. Okay, 30 milligrams of mercury. How do you measure it? There's all these devices your ERs might have, your orthopedic colleagues might have. We have one brand name in our department called Stryker, a Stryker instrument, where you put just a needle in and it measures the pressure, and that's how you know what the pressure is. If it's elevated, they have to go off to the OR and get fasciotomies and open up those layers. All right, wound care. 37-year-old male in good health presents with a 4-centimeter laceration in the mid-volar forearm after punching a glass window. His last tetanus was about 12 years ago. Which one of the following statements is true? A radial nerve deficit would result in a lack of a pincer grasp. B, neurovascular examination, a median nerve deficit would demonstrate inability to spread the fingers against resistance. Wound irrigation with tap water has been shown to have comparable, if not lower, rates of wound infection as sterile saline. Or D, X-rays are only indicated if the glass is known to contain lead. Good, excellent. C, yeah, you guys got it. C, wound irrigation with tap water is a good choice. So, wound care, when it comes to tetanus, I'll just go over this real quick. There's rare cases in the United States of tetanus now. It's somewhere between 20 to maybe 40 cases max per year in the United States. It's mostly patients who have never been immunized before. or immigrants and just never had a primary series for tetanus. Now, again, the CDC says you give a tetanus immunization or prophylaxis every 10 years for clean wounds, and if it's a dirty wound, every 5 years if it's a dirty wound. You can use it in pregnancy, and yes, I know David covers this, but what you do is you use the Tdap once. You substitute that once for the TD, and then go back to your TD booster every 10 years. So Tdap once if they haven't had it, then go back to TD. Okay. Then the neuro examination of the hand. They love to ask this question. I know Dr. Geary just did a little bit with you. I'm going to do it one more time. They love to ask this question. I told you, like to go back to basic anatomy. So follow along. Radial nerve, sensory, is on the back of the hand, right? Thumb, index, middle, and radial side of the ring finger. That's sensory of the radial nerve. What does the radial nerve do? Motor-wise, it helps with extension of the wrist and fingers. Median nerve, sensory is just the opposite side, the palmar surface of those three fingers and the radial side of the ring finger. That's median nerve sensory. What does it do? It helps with pincer grasp, median nerve. What I like to do, have patients do, is make the OK sign. If they can make the OK sign, their median nerve is okay. Last is ulnar nerve. The ulnar nerve, sensory, ulnar side of the hand, little finger, ulnar side of the ring finger. And what does it innervate? It innervates the interosseous muscles, the lumbricals, and those are used to hold your hand and the fingers spread wide apart, and you can test against resistance, and if you're able to resist, your ulnar nerve is fine. If you're a Star Trek fan, you can make the Vulcan sign, your ulnar nerve is fine also. Okay? All right. All right, irrigating with tap water, good idea. It's really a good idea. Why? Because you can get a lot more fluid into that wound and clean it out better than I can at my little irrigation station with my sutures, right? So, when you're suturing somebody and your nurse has set up your little suture tray and you got this little, shot glass of saline, right? That's what you got. It's like 10 cc's. Squirt. That's all you do. So if you can get them over to the sink and get some tap water running, go for it. All right. So irrigate. You x-ray if you think any glass is there. Don't pour betadine right into the wound. And who do you put on antibiotics? We'll talk about this a bit more in the next section. But anybody who's got high-risk wounds, high-risk sites such as hand and foot, or high-risk mechanisms, the bites, or high-risk patients, immunocompromised patients. Last question. They love child abuse questions. So follow along on this one. Child abuse should be suspected in all the following except A, a 7-month-old with diffuse cerebral and retinal hemorrhages. B, a 2-year-old with 3 rib fractures after a fall. C, a 6-month-old with multiple lower extremity bruises from falls. Or D, a 20-month-old with a spiral fracture of the distal tibia. Okay, the answer is D, the 20-month-old with spiral fracture of the distal tibia. So I'll go over why the first 3 you should suspect child abuse. So A, the 7-month-old with diffuse cerebral and retinal hemorrhages. You hear them say retinal hemorrhages, you think shaken baby, right? You think shaken baby right off the bat. All right, 2-year-old with 3 rib fractures after a fall. All right, very good study out of the University of Colorado has shown that children, they're up until about the age of 3, their ribs are very hypermobile, okay? They don't crack. The only reason they end up cracking if someone takes a whack. All right, so rib fractures under the age of 3, high degree of suspicion. C, the 6-month-old with multiple lower extremity bruises from falls. We have a saying in the ED, if they don't cruise, they don't bruise. All right, so if they're laying in a crib at 6 months of age and they got bruises all over their extremities, it's not because they're falling, it's because they're being abused. Don't believe the story, oh, he kicks the crib a lot. Not to kick the crib so much that he's going to have multiple bruises, all right? So if you don't cruise, you don't bruise. However, once you start cruising, and you're a toddler, you can get what is known as a toddler's fracture. So again, those of you with children, when they get to that toddling age, they're toddling along and they're falling a lot, they can get a toddler's fracture. And you've seen how children walk, those infants walk, they do like this, and they'll sometimes spin out. And what they'll do is give themselves a spiral fracture of the distal tibia. That's a toddler's fracture. That's not abuse. So you don't have to call up social services in those situations. If, however, I saw a transverse fracture of the tibia, that's trauma, okay, in a child. So watch out. There's a difference there. And so those are my pearls about child abuse, and I'll say thank you very much.